Called to a 72-year-old female at a nursing home. The nurse on scene stated that the patient was diagnosed with a urinary tract infection 2 days previous. However, the nurse suspected that the patient had had the urinary tract infection for more than a week. The patient was prescribed antibiotics on diagnosis. However, she had only been taking them for approximately 24 hours. The patient had a history of Alzheimer's, dementia, and hypertension. The nurse stated that a GCS of 14 was normal for the patient. However, the nurse was unsure whether her current mental state was due to the dementia or infection-induced delirium. All vital signs were within normal limits. However, a secondary survey revealed that the patient had been suffering from lethargy, loss of appetite, and urinary problems for at least 1 week. The patient's vitals remained stable during transport. However, she was distressed and required a great deal of reassurance. I've treated 2 dementia patients so far whilst on this clinical prac, including the patient in this reflection. The patient in this reflection, as I stated before, was quite distressed, whereas the first one was actually rather calm and confused throughout the entire situation. I have had some experience with dealing with dementia before because my grandmother was diagnosed with Alzheimer's and dementia. And from that experience that I shared with my family, I could say that probably the greatest skill one could have in dealing with dementia is patience. A lot of patience. I would also say that a combination of my family experience plus what I have done in my prac so far has shown that I have the skills to effectively deal with dementia patients. The greatest issue, however, that we had in this case was trying to determine the full extent of the UTI. The patient's vital signs showed little evidence of an infection. However, the patient's loss of lethargy, loss of appetite, and urinary problems indicated that there could be an issue. Evidence of delirium would have aided in our provisional diagnosis. However, the patient's dementia interfered with us making that determination. This is supported by an article by Gomez and Gomez in the 1989 Journal for Geriatric Nursing, which states that sickness and medication changes can induce bouts of delirium in dementia patients. A systematic review by Thick et al. In the Journal of the American Geriatric Society of 2002 also shows that there appears to be a low rate of diagnosis of superimposed delirium in dementia patients, with one report within the review showing 80% of superimposed delirium in dementia being undiagnosed by nurses. This would indicate that even well-learned medical professionals can have difficulty in diagnosing these patients. Despite this, there is evidence that there are notable differences in the presenting symptoms of delirium and dementia. The 1989 report by Gomez and Gomez states that changes in mental state caused by delirium are acute and fluctuating compared to the symptoms of dementia, which tend to come on gradually and then remain constant. The 2008 report from the American Journal of Nursing by Thick and Meon also recommended the use of the confusion assessment method, or CAM. The CAM identifies delirium if both of the following 2 features are present. Mental status altered from baseline, which has an acute onset or fluctuates, and inattention. And also if at least one of the following 2 is present, either disorganized thinking or an altered level of consciousness. The same report also states that delirium and dementia only share a common symptom of disorganized thinking. Therefore, any of the other symptoms may be indicative of delirium. And finally, the 2002 systematic review by Thick et al. Stated that certain medications, such as sedative hypnotics, antipsychotics, and cardiovascular drugs, can induce delirium in some dementia patients. Based on the evidence stated previously, if I were to come across a similar case in the future, I would question the nurse and or the patient's family about any changes in the patient's mental abilities, focusing on determining if those changes were acute and or fluctuated as per the CAM. I would also ask if the patient has any recent changes in medications This way I would be able to determine if delirium is present within the dementia patient and therefore be able to give a more accurate provisional diagnosis on handover. This should allow for a better overall care for my future patients.